Hi, everyone. My name is Mirza. I'm a hematopathologist at Loyola University Health System in Maywood, Illinois. I will be continuing the HemePath board review for Path Presenter slides 9 through 17. Case number 9, as you can see here, is a very blue lesion. We can't really tell if it's in a lymph node or not because it's kind of got no nodal architecture. There's no capsule or areas where we could identify any residual follicles. It looks very blue. It's got a slightly amphiphilic, like light purple appearance at this power. And also you can almost make out that their vague areas almost look like, little clouds that are on top of the lesion. But the main things to consider right now, I, a very cellular lesion. It looks blue, and it has no normal nodal architecture in the background, right? So there are no follicles that we can appreciate. When we go kind of intermediate, we realize that the cells are in sheets. They don't necessarily form any structures, but they do look like they're vaguely packeted or like put in small little nests. One of the important things here is that we can tell that this is a highly proliferative lesion because it has the starry sky appearance, the tingible body macrophages, in the contrast to the neoplastic cells are giving or imparting the starry sky appearance that you typically see with highly proliferative lesions. As I'm sure all of you have gone around and looked at different areas of this slide, you will have seen that all of the areas are similar. So there isn't necessarily an area where we have more like large cells or small cells. Effectively, it's very monotonous and it all looks like these intermediate sized cells that have kind of a clear chromatin and they have single prominent nucleoli. Uh, Mixed within this are lots of mitotic figures, so it's got a high proliferative activity. And other than that, it's a very monomorphic population, right? There's like really no larger cells, no background milieu of different types of inflammatory cells. And for those of you who have been wondering about the size of these cells, it's always a difficult consideration. You can try and find like a mature lymph or like a mature cell, or maybe even look at a red blood cell if you can see it in proper form. And you realize that these are not necessarily large cells. So if you were thinking of lymphoma, you wouldn't be thinking diffuse large B-cell lymphoma because for that, you would want to have cells that are at least 2.5 to 3 times larger than the lymphocytes. And if we are considering a hematopoietic lesion, which the disc cohesion kind of suggests, and even the nuclear features suggest, then one would consider any high mitotically active, kind of highly proliferative lesion, which could include Burkitt. However, while Burkitt has intermediate sized cells and squared off borders like this, the morphology and the nucleoli are unlike Burkitt lymphoma. This is unlikely to be a low-grade B-cell lymphoma because it doesn't look like it is mature lymphocytes. And so like any self-respecting hematopathologist, we'll probably start with a CD20 and a CD3. There isn't really a plasmacytoid appearance, meaning that this doesn't look plasmacytic. There's no cells that look like they're plasma cells specifically. And so our suspicion that this is a plasma cell neoplasm presenting nodally or extranodally is low. So we'll proceed with the immunohistochemical stains and we'll find that both CD20 and CD3 are negative. And then our repertoire will have to expand to include what this entity is. Naturally, if you already have flow cytometry, we will have an idea of what markers are positive and what are not. And in the next slide, we will discuss what this lesion is and what the immunophenotype for those cases are. So as I'm sure many of you have already guessed, this is a case of blastic plasmacytoid dendritic cell neoplasm, which is a clinically aggressive disease. The precursor for the neoplastic cells are plasmacytoid dendritic cells, and cases can present with skin, bone marrow, and leukemic presentations. This is a rare lesion. Male to female ratio is 3:1, and the mean or median ages are high, like older adults, like 61 to 67 years of age. Plastic plasmacytoid dendritic cell neoplasm typically involves multiple sites. Most commonly, the skin is affected in almost all cases. This is followed by bone marrow and peripheral blood involvement in 60 to 90% of the cases, and approximately half of the cases have lymph node involvement. Like we saw in our case, most cases present with diffuse monomorphic infiltrates of medium-sized blastoid cells. So they have irregular nuclear contours. In our case, they were kind of squared off borders. They have fine chromatin like we saw, and one or multiple nucleoli with scant cytoplasm. The immunohistochemical markers that are positive include CD4, CD43, and CD45, and the plasmacytoid dendritic cell markers CD56, 123, and 303. CD68 is positive with small cytoplasmic dot-like staining. CD7 and CD33 can commonly be expressed, and in some cases, TDT is also present. Two-thirds of the cases of blast-like plasmacytoid dendritic cell neoplasm have an abnormal karyotype. There are no pathognomonic cytogenetic lesions. However, 5q21 or 5q34 abnormalities are commonly seen in up to 72% of cases. For residents, I always remind them to remember 1, 2, 3, 4, 5, 6 of blast-like plasmacytoid dendritic cell neoplasm, and this is the positivity for CD123, CD4, and CD56. Cases have an aggressive clinical course with a median survival of only 10 to 19 months after diagnosis. Things that make this worse, adverse prognostic factors, include older age, a high blastosis in the blood, a low TDT expression, a low Ki67 expression, and deletions of CDKN2A or B. In this case, we are given an image of a child who seems to have a facial deformity due to the presence of a mass. And histologic appearance of this mass is seen here. The biopsy is in fragments. And you can again make out that this is a nodal lesion likely, and there's no residual nodal architecture. Unlike the last case, actually, even at low power, the starry sky appearance of this lesion is very, very prominent. Again, there are areas which are all the same. There's no area which looks very different. The fixation in this field looks like it might not be optimal. However, we can make out that there are sheets of cells and they're intermingled tingible body macrophages here, right? So this is, again, a highly proliferative lesion. And we are going to try and look for an area that is a little better preserved so that we can make out cellular morphology. So the cellular morphology here, it looks like they have overlapping borders in most of these areas, right? The cells don't look like they're large. They look like, again, they're intermediate sized, and they look like they have a very high mitotic rate. Moving around, we find that the lesion is very similar in multiple different areas. And again, the scattered mature lymphocytes in between kind of give us an idea that this lesion again has an intermediate sized cell, which is and they're mitotically very active. And then again, we'll have to perform some immunohistochemical markers in order to understand what this is. So we will start with CD20 and CD3, and CD20 will be positive, indicative of the fact that these are mature B cells. Again, they're not diffuse large B cell lymphoma because the size does not fit. I had gone around to try and find an area where you can see the classic squared off borders. However, it wasn't very, very apparent in this case. All right, so you put together the fact that these are CD20 positive cells. They are not large, they're intermediate. They have a starry sky appearance with high mitotic activity, and you can start putting together what the diagnosis will be. So as I'm sure many of you already guessed, this is a case of Burkitt lymphoma. Burkitt lymphoma is a highly aggressive but curable mature B cell neoplasm or B cell lymphoma. The reason we stress mature is because previously in the FAB, the cells, because of their cytologic appearance of being very blastoid, they were considered to be immature cells. However, with phenotyping, we know that these are mature B cells which have surface immunoglobulin and typically light chain restriction. There are three epidemiological variants of Burkitt lymphoma, and there's no single parameter in the diagnostic criteria which is gold standard, right? So you typically think of the starry sky appearance, that isn't pathognomonic. You think of MYC rearrangement by itself, that isn't pathognomonic. So it's interesting that, we make this diagnosis of Burkitt lymphoma. Every hematopathologist has in their minds an idea of what this diagnosis is. But according to the WHO, there's a lot of leeway in how this can present or look like. And so there's no single parameter that we can use as a gold standard. So the three epidemiological variants include the endemic form, which is associated with EBV in over 95% of cases. And if you read the WHO, there's an interesting association with Plasmodium falciparum malaria. The sporadic cases are also EBV associated, but only in 20 to 30% of cases. The immunodeficiency associated Burkitt lymphoma is typically seen in patients with HIV. However, EBV association is also seen in 25 to 40% of cases. Burkitt lymphoma involves extranodal sites quite often. There is CNS involvement as well. The risk for CNS involvement is present in all three of the epidemiological variants. The endemic form typically presents with jaws or facial bone lesions in 50 to 70% of the cases, and bone marrow involvement can be present, but typically it's not leukemic presentation at that time. Sporadic cases also present in the face and the jaw. However, compared to endemic forms, it is rare to see face and jaw tumors in the sporadic form. The sporadic form is more commonly seen in the abdominal area, especially in the ileocecal region. There can also be cases involving the breast. Immunodeficiency associated Burkitt lymphoma can be nodal and also have bone marrow involvement. Cases typically present with bulky disease. They have high tumor burden and a very quick doubling time. So if, for example, these cases are in any tubular structure, such as the GI tract, they can cause obstruction very quickly. If they are very close to the aerodigestive tract, they can actually cause compression because of the fact that they grow so quickly. On gross pathology, they have a classic fish flesh or lymphoid appearance with a bosselated cut surface. The cells on morphology are medium-sized, like we saw. They're diffuse and monotonous. They're cohesive, but with squared-off borders. And they typically have multiple paracentrally located nucleoli. They have deeply basophilic cytoplasm, which on touch imprints or cytologic examination, you can see lots of vacuoles in them. So it's deeply basophilic with these clear vacuoles. And as we saw, there's a high proliferation rate. Burkitt lymphoma is positive for B cell markers. Mature B cell markers like CD20 also includes other B cell markers. Germinal center markers such as CD10 and BCL6. They're also positive for CD38, CD77, and CD43. They express surface immunoglobulin. Upon IHC expression, there is typically strong MYC expression, and we expect the Ki67 proliferation rate to be very high. These cases are usually negative for TDT, CD5, and CD23. They should be negative for BCL2. MYC translocation is a hallmark of this disease, but again, there have been cases without MYC translocation that have been reported and diagnosed. In NGS studies, we have seen TCF3, also known as E2A mutations, in 70% of cases of sporadic Burkitt lymphoma. Cases of Duncan syndrome or X-linked lymphoproliferative syndrome have a higher incidence of Burkitt lymphoma. In general, though, this is a highly aggressive but curable disease. Intensive chemotherapy regimens have led to long-term survival of 70 to 90% of cases. Adverse prognostic factors include a greater than 10 centimeter size of the lesion, advanced stage, CNS involvement, and high LDH. The next case here is involving the GI tract. You can make out that there's a very nice colonic mucosa with some lymphoid aggregates, likely with reactive looking germinal centers here as well. As you follow this along, you find that there is now an outpouching of this with kind of a dense lymphoid infiltrate, which is going pretty deep. And you can see that it's kind of coming up into the epithelium as well. Within it, there could be some follicles that you can make out at this power. However, overarchingly, it's giving you a vaguely nodular appearance. So as we go in, we take a look and see there isn't necessarily direct invasion of the epithelium. So you can't really make out lymphoepithelial lesions. The nodularity in a lymphoma lesion like this, especially with some residual germinal centers, is obviously highly suspicious of a low-grade B-cell lymphoma. In order to confirm that, obviously, we'll have to go in higher. There are some residual follicular structures. However, if you take a look at the cells, they're very monotonous. They have kind of an abundant cytoplasm, as you can see that it's a clearing around them. They have scattered immunoblasts in between that I just pointed out. There are basically slight irregularities in the cells in general, but it's just a monotonous appearance. The cells are small, they are not large, and you can tell that by looking at the larger interspersed cells which come in once in a while. And then again, there are some residual follicles. However, this doesn't necessarily, like here, right here, there's another follicle, but it doesn't look like this is a follicular expansion, right? And so the B-cell lymphomas that you can get, which are kind of small B-cell lymphomas in the GI tract, include all of the low-grade B-cell lymphomas. And we try and make a differentiation based on immunohistochemistry. So again, like every self-respecting hematopathologist, we will start with CD20 and CD3. These cases will be CD10, CD20 positive, diffusely. These are all B cells. And then in the next slide, we will discuss what this lesion is. So indeed, as many of you guessed, I'm sure, this is a marginal zone lymphoma or an extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue, MALT lymphoma. It's comprised of morphologically heterogeneous small B cells that are typically monotonous, and lymphoepithelial lesions are common wherever there are epithelial structures. Marginal zone lymphomas, basically a 7 to 8% of all B cell lymphomas and typically present in the seventh decade. Up to 50% of primary gastric lymphomas will actually be MALT lymphoma. There is an association with chronic inflammation. For example, in autoimmune conditions such as Sjogren's or Hashimoto's, you do have higher incidence of salivary MALT or thyroid MALT respectively. There can also be chronic inflammation in cases of infection, such as H. pylori, which is associated with gastric MALT, and the chlamydia psittaci and Borrelia association with ocular MALT. So stomach is again most common. 35% of cases of MALT will be presenting here. The eyes and ocular adnexa are second most common, up to 13%, and then skin involvement can be seen in 9% of cases. When presenting, the cases usually present in stage 1 or 2 disease. Bone marrow involvement can be seen higher in cases of non-gastric MALT. So if it's a gastric MALT, you don't really expect that the bone marrow will be positive, but a non-gastric MALT will likely have bone marrow and leukemic presentations. These cases are B cell lymphomas with plasmacytic differentiation, and often you can also find a small serum paraprotein. Morphologically, they are small to medium-sized cells. They have relatively abundant but pale cytoplasm on H&E sections. This abundant cytoplasm with slight irregularity in the nuclei give them a monocytoid appearance. Their plasmacytic differentiation is obviously there, and then you can also see amyloid deposition in some cases. Large centroblast-like cells are present, but they're few and interspersed. We saw some of those in our case. In the lymph nodes, typically this, marginal zones are present in like pelvic lymph nodes normally. And when involving lymph nodes, the marginal zone lymphomas will go into the marginal zone areas, right? So they'll be outside the follicles. However, they can also replace or colonize follicles, and they present as very nodular lesions, and it can be very difficult to diagnose and separate from follicular lymphoma without immunophenotyping. Lymphoepithelial lesions are seen wherever these are destroying epithelial structures, and these are defined as greater or more than or equal to 3 marginal zone lymphoma cells that are distorting the epithelium. So the cases are positive for mature B cell marker CD20. They're also positive for CD79A, and CD43 expression is variable. I typically use CD43 in the aerodigestive tract because CD43 typically is a T cell marker, and its expression in B cells is very helpful to identify a clonal process. They typically have restricted surface immunoglobulin. The hallmark of this lesion is that it is typically CD5 and CD10 negative, right? So these are the CD5, CD10 negative small B cell lymphomas. CD23 is also negative in these cases as well. Very rarely can CD5 or CD10 also be positive, but BCL6 is almost always negative. These cases have both heavy and light chain rearrangements, and there are numerous cytogenetic translocations or trisomies that are affiliated, but none is pathognomonic. TNF-AIP3 abnormalities have been seen, but they're again not specific for MALT lymphoma. Clinically, this disease has an indolent course. It is slow to disseminate, and transformation to diffuse large B-cell lymphoma is seen in less than 10% of cases. All right, this is the next lesion. It is a nodal lesion. It has a vaguely nodular appearance. Again, similar to what we've seen before. Another thing is that it also has these areas, if you can probably make out, which look like they're clouds on top of the lymphocytes. That's kind of how I like to look at it. If we were looking at it live, I would probably dim the light of the microscope. And as the light became dim, you could see these areas, which are probably areas that have more abundant cytoplasm, right? So that's why they're more pink. These cases, again, this is a low-grade B-cell lymphoma. The cells are very, very monotonous, and they're small. When we go in, you can tell that really they're just mature. The chromatin is clumped. There's really a dearth of larger cells, and these small cells are kind of traversing through all tissue. There's no residual normal architecture left, right? And so you're thinking mature cells, probably B cells, right? And so a mature low-grade B-cell lymphoma, it doesn't seem to have a high mitotic activity. So again, you'd start off with CD20 and CD3. These cases are going to be CD20 positive. And as many of you guessed, this is small lymphocytic lymphoma or chronic lymphocytic leukemia, which is the same entity, just presenting in different ways. CLL/SLL is a disease of monomorphic small mature CD5 positive B cells. The monoclonal B cell count in the blood needs to be more than 5,000 per microliter in order for it to be called chronic lymphocytic leukemia. When it presents as nodal disease, it's called small lymphocytic lymphoma, but however, the convention is to typically call it CLL/SLL. These are pretty common, most common non-Hodgkin lymphoma of Western country adults, really 7% of non-Hodgkin lymphomas here. The incidence is between 5 and 20 of 100,000 cases. Highest incidence is in patients over 70 years of age. There can be blood, bone marrow, nodal or extranodal involvement, and most patients are often routinely found and they're asymptomatic, right? So it could just be your PCP visit and it's got on blood CBC. Less often, they can present with nodal disease, actually, or be symptomatic at presentation. Approximately 10% of patients also present with a small IgM paraprotein. Cases of CLL/SLL, the patients have typically reported to have severe allergic reaction to insect bites. When present in lymph nodes, the lymph nodes will be enlarged with the diffuse proliferation of small monotonous lymphocytes and variably prominent paler proliferation centers, which are also known as pseudofollicles. So the paler areas that I was trying to point out to you were those pseudofollicles. There is in general a low mitotic activity. When you look at the blood, you typically see these mature soccer ball cells, where everyone has seen them, mixed with the smudge cells and prolymphocytes. Prolymphocytes have larger lymphoid cells with prominent nucleoli. The soccer ball cells have been described differently, right? This is just because of the irregular condensation of the chromatin in the nucleus. They've been called chocolate chip cookie, pepperoni pizza, but the idea is that there's blotches of chromatin condensation in a paler background, which gives that soccer ball appearance. In the bone marrow, if it's involved by CLL/SLL, there can be nodular, interstitial, or mixed or diffuse, right? So basically, the infiltrates can be in any shape or form, but typically paratrabecular infiltrates are not seen because we typically think of follicular lymphoma. Cases are positive for CD19. They typically have dim CD20 expression and dim CD5 co-expression. They also have dim surface immunoglobulin, but it's restricted. Cases are almost always positive for CD200. FMC7 is negative, which is a helpful indicator that this is not mantle cell lymphoma, which is usually FMC7 positive. Cases of CLL/SLL have a familial disposition in 5 to 10% of the cases they present. 80 to 90% of them have cytogenetic abnormalities. However, there's no pathognomonic or specific genetic markers to help define this disease. Most commonly, though, you can see deletion 13q14.3 or trisomy 12. Mutations of Notch1, SF3B1, ATM, BRC3, POT1, and MYD88 have been seen in between 3 and 15% of cases. Clinically, there are two different staging systems that can be used for kind of prognostication and staging of these cases, which are the RAI and Binet. 2 to 8% of cases will develop DLBCL, which is known as Richter's syndrome or Richter's transformation. When that transformation occurs, it's associated with TP53 and Notch mutations. It can also be associated with CDKN2A deletion or MYC translocation. There is a transformation to classic Hodgkin lymphoma. However, that's rare, with only less than 1% of cases transforming into Hodgkin lymphoma. If there is not 5,000, if there are not 5,000 monoclonal B cells per microliter in the blood, but they're clonal anyway, you call them monoclonal B lymphocytosis. These can be defined as a CLL phenotype-like, an atypical CLL phenotype-like, and non-CLL type as well. All right, this is the next case. Again, this is a nodal lesion. There's some areas of probably necrosis that you can make out at this power. So we're already wondering that this is probably a high-grade lesion. It's got slightly paler zones and darker zones. And in general, it looks like it has been dissected off into these larger nodules. So if we go in and take a look, we find that actually indeed there is like extensive necrosis here. And the cells, unlike the cells we've been looking at before, are not small. These are larger cells. And you can tell that they're large because if you look at the background cells that are trickling through, these are 2, 3, 4 times larger. They're very pleomorphic. Their nuclei, you can tell they have kind of hardened nuclear membrane. See how like distinct that nuclear membrane is? They start having like these irregular nuclear contours. In many cases, they have prominent cytoplasm, prominent nucleoli. They also do have prominent cytoplasm. It's pretty abundant in many areas. And then you can start seeing that the nuclear irregularities become greater and greater, right? So these are just sheets and sheets of these large cells that are extremely pleomorphic. And you know, in this case, I was actually trying to look for the classic hallmark cells that you're associating whenever, or you're looking for whenever they're pleomorphic lesions. So you see lots of mitotic figures here. And actually, I wanted to annotate like a cell that looked like it was probably a hallmark cell. But to be honest with you, I couldn't really find many. And so I'm sure when you looked around, you were able to find some cells that look like the classic hallmark cells, which would be indicative of the fact that this could be potentially an anaplastic large cell lymphoma. However, again, and you know, in some areas it's difficult to see at this power though, but you can see that these discohesive cells are actually floating around in the sinuses as well. Right, so maybe if we were to really squint your eyes, you can see that there, right in the center here, there is a cell with a horseshoe shape. Maybe typically you think of hallmark cells to have a pinkness or like a nice eosinophilia that is kind of in the center of the indentation of the nucleus. That's usually the description of a hallmark cell. So as you've probably guessed from the description that I'm trying to provide, you know, you would again start with CD20 and CD3. Most likely both of those cells, both of those stains would be negative actually in this case. And then you'd be like, well, this is very pleomorphic. Let me throw a CD30 on it and it would just light this entire lesion up. And yes, this is an anaplastic large cell lymphoma. So anaplastic large cell lymphomas are T cell lymphomas which have large pleomorphic cells. There are ALK positive and ALK negative varieties. For purposes of this presentation, I'm just going to discuss this as an ALK positive lesion. The hallmark of this is the CD30 positivity. ALK positivity in ALCL, these cases usually involve lymph nodes and extranodal sites, which can include skin, bone, soft tissue, lungs, and liver. There is mediastinal disease, but it's less frequent than classic Hodgkin lymphoma. Bone marrow involvement is often subtle, right? So it's like very little. So there were cases that reported approximately 10% of bone marrows being involved, and these did not use IHC. And so the use of IHC has actually slightly increased the frequency of incidence of bone marrow involvement by anaplastic large cell lymphoma. There are some cases of isolated skin-specific disease, which actually doesn't have a bad prognosis. Most cases, approximately 70% of them will present with advanced stage disease, which will have both peripheral and abdominal adenopathy. 75% of cases will also have B symptoms, especially high fevers when they present. The morphologic spectrum is broad. All cases contain a variable number of these hallmark cells that I was trying to describe. We did see one of them. You typically think of it as a horseshoe-shaped nucleus with an eosinophilic region which is near the nucleus. Several morphologic patterns have actually been identified. So there's even a small cell variant of an anaplastic large cell lymphoma. You can read in the WHO for details. So when you look at CD30, there should be membranous and Golgi positivity for CD30, but the smaller cells, and this is in the large cells, and the smaller cells may actually be only weakly positive for CD30. So if you were thinking of ALK positive ALCL, most cases will have translocation 2-5, which is the nucleophosmin 1 and ALK rearrangement. ALK staining of the cells is both cytoplasmic and also nuclear. There is typically positivity of EMA, and usually more than one T cell marker is positive in these cases. However, that's not usually CD3, which is negative in 75% of the cases. There is defined T cell null cell phenotype entity in which basically you effectively have no T cell markers at all. You have to differentiate these cases from ALK positive variants of diffuse large B cell lymphoma. You also have to consider that rhabdomyosarcoma, inflammatory myofibroblastic tumor, and some neural tumors may also be ALK positive, but those are all CD30 negative and they can be morphologically distinguished from ALCL. So there can be NPM1 ALK tumors and also some variant ALK mutations, translocations. However, there's no difference between those basically when it comes to outcomes. And the long-term survival in ALK positive cases approaches approximately 80%, and this is very different from ALK negative cases. Even if the patients relapse, they often remain sensitive to chemotherapy. All right, the next case also is just fragments of tissue that look lymphoid. In this fragment, we can make out that there are squamoid islands kind of here. And so most likely we are in an area which has a mucus lining. Again, these squamous islands are present. I'm trying to find angio-invasive and angiodestructive kind of lesions here or necrosis. And because it's a small fragment, it isn't very, very obvious. However, again, this is a lymphoid lesion, and this lymphoid lesion is comprised of mature cells. It's a little bit of a mixture, right? So you can tell that there's some slightly larger cells, some smaller cells. You can even make out some plasma cells in between, right? So it looks like it's a very mixed pattern of inflammation, right? And so it's very easy to consider that this particular entity is just an inflammatory infiltrate, especially when it is presenting in its usual location, which is the sinuses or the nasopharynx. And in there, you can tell that within the background, there's also a sprinkling of all of these lymphocytes and plasma cells going through. So you'll again perform CD20, it will be negative, but CD3, depending on what marker you're evaluating CD3 with or which method you're doing it with, might be positive. So hold on to your hats. So this was a case of extranodal NK T cell lymphoma nasal type. It is a predominantly extranodal lymphoma of the NK/T cell. So not specifically NK cell, not T cell, right? The NK/T cell. It usually presents with vascular damage, prominent necrosis, and EBV positivity. Very common in Asians and indigenous populations of Mexico, Central and South America, usually involving patients who are adults between 44 and 54 years of age. The strong EBV association is irrespective of ethnicity, and there is a disease activity which you can monitor by measuring circulating EBV DNA, right? So the EBV is strongly associated with it. It's almost always extranodal. The upper aerodigestive tract, the nasopharynx, and the paranasal sinuses are usually the common places, but the nasal cavity, as the title suggests, is the prototypical site. The presentation can be with nasal obstruction or also with epistaxis. There can be extranasal cases, right? So that's nasal type extranodal NKT cell lymphoma, which is in an extranasal location. They also can have variable presentation. So patients will present with extensive ulceration. The infiltrate will be diffuse. It should have angiocentric and angiodestructive growth pattern, and the cells are small, medium, large, or even can be anaplastic. The big problem here is the fact that the mixed inflammatory background can mimic an inflammatory process, right? So you have to have a high index of suspicion for these cases. These cases will be positive for CD2, negative for CD5, positive for CD56, negative for surface CD3, but cytoplasmic CD3 epsilon chain will be positive. In these cases, CD56 staining is useful, but again, it's not specific. The CD45, CD43 immunostains are usually positive. CD7 positivity is variable. These cases are negative for CD4, CD8, CD57, and CD16, while they are positive for all cytotoxic markers, which include granzyme B, TIA1, perforin. The prognostic importance of cytologic grade, right? Just looking at the cytology of the cells has been very controversial. There is no specific chromosomal abnormality. However, between all of them, the deletion 6, Q21, Q25 is most common. Cases of extranodal NKT cell lymphoma nasal type have a variable prognosis. Historically, the survival rate was very poor, but this has improved recently with more intensive regimens and upfront radiotherapy. Adverse factors for the disease are advanced stage, bone and skin involvement, high EBV titers, and high Ki67 proliferation. The next case is a lymph node. You can see that there is a fibrotic capsule kind of all around it. There is some residual lymphoid architecture, right? So we can make out some reactive looking follicles. But within the kind of cortex and paracortex, you can see that there are these clusters of pale cells. So the cluster of pale cells is basically where we're going to go and take a look and see what they are. These clusters of pale cells have abundant pink cytoplasm. And in many cases, you can see that the nuclei kind of curved. They are a little bit even groovy. Let me try and find, like, if you see certain areas which have lines inside them, right? So now these clusters are obviously, what you're considering is that they might be Langerhans cells. And you see these little guys, right? Everybody probably saw the little EOs in the background, right? So whenever you have a histiocytic kind of an appearance and you have grooves in the nuclei and you have EOs in the background and these cells are present in clusters, again, you're obviously thinking one disease. And so we're going to talk about that. Just to rule out any other thing, the follicles are not expanded. They are kind of reactive looking with some polarization as well. And so the main issue basically is with these cells. So these are Langerhans cells by morphology, but we have to prove that by immunohistochemical staining. So this is LCH. Langerhans cells, histiocytosis are within the subset of tumors derived from Langerhans cells, and it is a clonal expansion of Langerhans cells, which are CD1A, Langerhans, and S100 positive with Burbeck granules present on EM. Typically, the incidence is 5 cases per million patients. Most cases are in childhood. The male to female ratio is 3.7 to 1. In contrast to other settings, the primary LCH of the lung is almost always a smoking-related disease. LCH can be single site, multiple sites within a single system, like such as in bone, or it can be multi-system, such as disseminated disease. The dominant sites of involvement in solitary form are the bone and soft tissue. So the skull, femur, vertebral column, pelvis, and ribs. If patients are presenting with unifocal disease, they're typically older children or adults, and they present with lytic bone lesions. If there's multi-system involvement at presentation, that usually is an infant with cytopenias, fever, skin, and bone lesions. The key feature of LCH is obviously the presence of LCH cells, and if you do ultrastructural examination, there should be Burbeck granules, which are tennis racket-shaped granules. On histology, the cells are oval with grooved or indented nuclei, inconspicuous nucleoli, and delicate nuclear membranes. The background milieu includes EOs, like we saw in our case, histiocytes, which also were present in our case. Actually, there were lots of histiocytes in the background, and scattered lymphocytes. Occasionally, you can actually have eosinophilic abscesses and also Charcot-Leyden crystals. LCH cells are positive for CD1A, Langerhans, and S100. The Langerhans positivity is very common in because of the Burbeck granules. They're also positive for Vimentin, CD68, and HLA-DR. Markers of B origin, T origin, or follicular dendritic cell origin are absent. This is a clonal disease. Half of the cases will harbor a BRAF V600E mutation. 25% of cases also harbor somatic MAP2K1 mutations. There is a high concordance in LCH between in identical twins, but not in dizygotic twins. The clinical course is related to staging of the disease at presentation, with more than 99% of survival in unifocal disease. Interestingly, BRAF V600E mutations do not affect the prognosis. All right, the last case in this section is this very dense proliferation of cells that is associated here with some fibrovascular kind of tissue. There's no real, so this is an extranodal presentation most likely. There's no architectural, that's residual that would kind of remind us of where we are. And actually the cells all across the area, they're very similar. So there are spindle to ovoid cells. They're very large. You can see a trickling of like small lymphocytes through the background. It is a high-grade lesion with a high mitotic index, right? So when they're large cells, you would think of diffuse large B-cell lymphoma, but these are too spindled and kind of ovoid, right? And so you're thinking that, well, could they have a histiocytic type of an origin or a kind of a follicular dendritic cell type of origin? However, this is all guesswork because without the stains, you will not know what this is. However, when you see this, your differential should include DLBCL most likely, or other hematopoietic lesions. As I'm sure many of you guessed, this is follicular dendritic cell sarcoma, or FDCS. That is a neoplastic proliferation of spindle to ovoid cells with morphologic and phenotypic features of follicular dendritic cells. This is a rare disease. The patient age range presentation is really wide. So it's from childhood all the way to adulthood. However, adults predominate. A proportion of cases occur in the setting of hyaline vascular variant Castleman disease. Castleman disease could be concurrent to FDCS or also be preceding the lesion. Like in our case, it is an extranodal disease in 8% of the cases. Lymph node involvement is seen in a third approximately, and both extranodal and lymph node disease is seen in 10% of cases. Most cases will present with localized disease, and systemic symptoms actually are uncommon. The cells are present in fascicles and whorls and storiform arrays of spindle to ovoid cells. They're present in diffuse sheets or nodules. The cells have indistinct borders sometimes with moderate eosinophilic cytoplasm. They can also have nuclear pseudoinclusions, and typically they are also binucleate cells present. The mitotic rate ranges from 0 to 10 cells in 10 high power fields. And as we saw in our case, you typically have a background that is infiltrated by small lymphocytes. Birbeck granules are not seen on electron microscopic examination. Follicular dendritic cell sarcoma is positive for one or more FTC markers that include CD21, CD35, and CD123. CXCL13 and D240 basically staining is also positive, but it's not specific for follicular dendritic cell sarcoma. Clusterin is usually strongly positive, while there's variable positivity for S100, CD68, and EMA. MPO, CD34, CD79A, and HMB45 are negative, and the admixed lymphocytes are predominantly B cells, but they can also be mixtures of B and T cells. The BRAF V600E mutations that were common in LCH are also reported in follicular dendritic cell sarcoma in like less than 20% of cases. These cases are usually treated with complete surgical excision with or without adjuvant radiotherapy and chemotherapy. The local recurrence rate is 28%, and distant mets can be seen in 27% of cases. However, the true numbers, like these are just studies from like 2 cohorts, the true numbers are likely higher according to the WHO. The 2-year survival rates for early disease is 82%, for locally advanced disease is 80%, but for cases with distant mets, it goes down to 43%.